So from a interesting topic but a difficult one of ODS, we come to the important area of proctology practice, peri-anal fistula, where the surgery is not often very favorable outcomes. But to help us understand anatomy better in a way to deliver results, may I invite Dr. Saunak Paul to give his talk on MRI in peri-anal fistula.
Good morning, everybody. I am really honored to be invited to this, and I thank the organizing team for this. So my talk will be mostly images, unlike the previous talks, and I think you may interrupt me at any point of time during the talk if anything needs to be discussed. So when we talk about peri-anal fistulas, the two main classification systems that we discuss are the Parkes classification and the St. James classification. The Parkes classification being from the surgical point of view, whereas St. James classification is a radiological classification. And coming to the differences between the two, St. James includes axial imaging as well for evaluation of the fistulas. And the abscesses and secondary tracts, which are clumped up together as complicated fistulas in Parkes classification, are dealt in and given separate standings in the St. James classification. So we will just discuss a bit of the anatomy. This is the external sphincter. This one is the internal sphincter, and the high signal intensity linear structure here is the mucosa. Next, this is the levator, and this one again is the external sphincter. So this is the basic anatomy of the anal canal, relevant for our peri-anal fistulas. Coming to the first, grade 1, St. James, it's a simple intersphincteric fistula with no side branches, no abscesses in the intersphincteric plane. So on the sagittal image, this is a proton density fat saturated image. We can see there is a, I think the pointer is visible, yeah. We can see there is a high signal intensity linear structure at the inferior margin of the posterior aspect of the anal canal. And on the coronal image, we can see the entire length of the fistula with no side branches. So this is an axial imaging. We take two orthogonal image as a basic radiologic imaging protocol, and for this we use the axial and the coronal. So this is the anatomy, normal anatomy at a higher level for the same patient. This is the internal sphincter, this part is the external sphincter. As we go further down, we can see the opening in the internal sphincter at 7 o'clock position, and on subsequent images the external opening at the level of the peri-anal skin at 6 o'clock position. So this is a second patient we have for St. James grade 2. This person has multiple fistulous tracts in the intersphincteric plane. This is the primary tract that goes up to the level of the internal sphincter, and this is another secondary ramification of the primary tract. On axial imaging, this sagittal is not acquired. This is a 3D reformatted sagittal, so it looks weird, halfway cut. And this is the axial. We have the two fistulous tracts at 2 and 3 o'clock positions, and this is the coronal, the acquired one. We have the two tracts that has seen. Coming to the next, grade 3 St. James, this is a transsphincteric fistula in which the internal sphincter and the external sphincter both are breached, and the tract moves on to the ischial-anal fossa, and through the fat extends up to the level of the cutaneous opening. So I'll run through the images. The upper data set is a non-contrast set, and this is the internal sphincter, the opening at the internal sphincter, the crossing at the level of the external sphincter, and the entire length of the fistula in the peri-anal, in the ischial-anal fossa. So this patient was administered contrast. This is an academic interest that we administered contrast, though the tract is so well visualized, we don't usually recommend giving contrast. So one small suggestion, please mention in your tickets plus minus contrast. That helps the radiology team to take a decision whether contrast is necessary or not. And this is the enhancing part of the fistula where the internal sphincter is breached, and this is the entire part of the fistula in the peri-anal region, and there is extensive enhancement. This is the enhancing part, and this is the non-enhancing part. You can see the amount of inflammation along the fistulous tract. So this is another patient who was treated earlier, some 4 years back, and he presented with some mucus discharge from the site of the skin opening. On the first image at the level of the fistulous opening with the internal sphincter, this is all fibrous. This is black. This is hypointense, what we call on MR. When we go on a inferior image, is it appreciable? This is a bit more whitish. So this is iso-intense. When we call iso-intense or hypo-intense, we compare with the available anatomy in the zone. The most common used is the muscles. So when we use the muscles here, this is blacker than the muscle or hypo-intense with respect to the muscle. And in this is iso-intense with respect to the muscle. So we move on to another sequence. This is a proton density sequence. Proton density sequences are made for pathologies which have high water content. In this also we don't see much of hypersignal intensity within the proton density images. So in this patient, he still has a complaint and we don't find any active fistulous tract. So this is the patient where we choose to give contrast. And on post-contrast imaging, there is minimal enhancement along the inferior aspect of the treated part of the fistula, which is better seen on the reformatted sagittal image. And this is only a residual sinus tract of the inferior part of the fistula that is secreting mucus, and this is the reason the patient has come back for re-imaging. So coming to the next one, grade 4, this is transsphincteric fistulas associated with abscesses either in the intersphincteric plane or in the ischioanal fossa. So this is the abscess that is all through and through the external sphincter, and this is the big fat fistulous tract. This person had a partial sphincterotomy of the external sphincter extending from 3 to 6 o'clock position, and the external sphincter we can see is partial here, and it is not seen in this position. So the abscess extends from the whatever residual intersphincteric plane is there into the ischioanal fossa, and that is how we incorporate abscesses and side tracts into this new system from Parks. So going to St. James grade 4, both supralevator and translevator diseases are involved in this grade, whereas in the supralevator disease, the fistula goes above the level of the levator without breaching the levator muscles. So this example is of a supralevator disease. There is some amount of abscess in the peri-anal region here, and there is intramural abscess in the lower third of the rectum. The communication is through and through without breaching the levator muscle. So we'll go to the relevant axial imaging. So at this level, this is the levator, and this part is the lower third of the rectum. We have an intramural abscess extending all the way from 3 to 11 o'clock position. And when we go at a lower plane, there is a defect in the external sphincter, part of the abscess in the intersphincteric plane, and a horseshoe-shaped abscess in the peri-anal or the in the ischioanal fossa. So the major part of an MR imaging is to identify the internal opening. That's where the recurrences are commonly seen, and it's easily identified on thin sections, and this is an opening at around 6 to 7 o'clock position. Another opening at 5 to 6 o'clock position with a meandering of the fissurous tract in the intersphincteric plane. And MR helps in identifying the predictors of poor surgical outcome, like unidentified internal opening and primary tract that has not been diagnosed properly, and a secondary tract or a small abscess that has not been picked up. The idea is to preserve continence and reserve the diversion colostomies for extensive diseases like Crohn's, in which there are multiple fistulas all around. And MR also helps in people with medical treatment of Crohn's, in which the skin site has closed. So I would like to close my session here. Thank you so much.
Thank you very much, Saunak, for presenting such wonderfully the topic which is very poorly understood by the surgeons, but still it helps a lot in planning our surgeries. Any questions?
So,
nice presentation, enjoyed, thank you.
thank you so much, sir.
Often we find that, it's not often, but infrequently we find that on the MR, the internal opening is not identified.
Yes, sir.
And on clinical examination, it's possible to feel the internal opening.
Yes, sir.
Why is that?
If you are doing a routine MR protocol with a 4 millimeter sections, the internal opening will not be seen. So these are the sections, 4 millimeter sections. And am I audible? The protocol for MR is to keep a 10% slice gap. So if we are doing this, if we don't give a slice gap, there is a chance of signal overlap. The volume data from here can overlap into the volume data from here. So the basic imaging has a spaced thing. So if your fistulous tract internal opening is somewhere in the space which is not imaged, it is not seen. That is why we do 2 orthogonal plane imaging at minimum. And some centers, if we are not pressed for time, we take a 3rd image on a sagittal plane. That occasionally helps, but not always. Then again, there is this concept of volume averaging. Suppose part of the fistula just lies, internal opening just lies on the inferior margin of this volume stack. So part of it is here, part of it is here. It is not seen in either of them, because the rest of the anatomy that gives us the image in the case space, I mean, we call it case space, the basic thing that acquires the image. The entire volume, only part of it is from the fistula. So this is obscured by the rest of the imaging signal that we get from here. The better part is when we do a 3D imaging, in which we take 1 millimeter contiguous sections. The imaging signal is way poor, but the anatomical evaluation is better. So please ask your radiologist to include a 3D, I'll try to send it over, 3D proton density fat saturated images. So that will help you to identify the fistulas in roughly more than 95% of the cases. If you don't take that 3D image, most of the times when you take the 2D images, you might miss the internal opening, sir.
Yes.
Will it add to the additional cost for 3D imaging?
No, sir. It is part of the non-contrast imaging protocol. It takes 3 to 5 minutes more. It's basically your rapport with the radiology department. You can just go and tell them, please do this sequence. They will always oblige.
Why not just include in the protocol and just give it?
Sir, in high volume centers, taking a 3D takes 5 minutes. And compared to that, if you have a stroke takes 5 to 6 minutes. And those minutes in a corporate sector, it is difficult to incorporate that until you are pressed for it. Contrast, please don't advise contrast as a complete thing. Keep it for the radiologist to decide whether it is required or not, because gadolinium is good, but it has its own side effects, and we are very, very scared of gadolinium.
So,
Sir, many of the times they do this transrectal ultrasound rather than MRI.
Yes.
So
My personal experience, it is better.
transrectal is
Yes.
better.
And if it is a female, it is even easier. You go transvaginally, go along the posterior vaginal wall. You see the entire anatomy, and the delineation is absolutely nice. You can map up the entire fistula. If your radiologist is comfortable doing it, the transrectal ultrasound, it is not transrectal per se. We call it transrectal. It is a transperineal ultrasound. We prop up the legs, open it up, put the transrectal probe, no other probe, transrectal probe on the perineum, and sweep it from craniocaudally. So within that sweep, you can get the images. You save that video loop, reassess. It's very, very easy. It's cheaper, and only thing that a local expertise is the problem.
And how sensitive is it?
As good as MR.
MR.
As far as I
the
have
high
practiced.
fistulas and secondary tracts.
High fistulas, it is difficult. For St. James 5, it is difficult. And in that cases, I think you will have to go back to MR. For low fistulas, this should be the norm to get a transperineal ultrasound with a transrectal probe, not with the other probe. And that will give you better delineation, because on MR, the imaging can be done at 0.1 millimeter range. Okay. Whereas for ultrasounds, for MR, it is at minimum at 1 millimeter. So you have 10 times more resolution with a ultrasound.
And one more doubt is, in case of recurrent fistulas,
Yes, sir.
with complex tracts.
Recurrent fistulas with complex tracts, always go for a MR with contrast.
Okay.
With you contrast. Have lasered it first, and post laser it is fibrosed partly. Halfway through the tract it is a sinus, so it is always better to get an MR, possibly with a contrast. Yes.
Thank you.
Yes.
Any more question? I think Dr. Paul, you explained it so good that you came out with the basic first and then step by step. And this is a surgery, always discuss MR with your radiologist. Like whenever I'm doing a fistula surgery, I will sit down in the console with my radiologist, so that you got a mapping in your mind when you are performing a surgery. Because this surgery has got quite a lot of recurrence. If you don't handle one of the track, patient will come back.
Definitely.
And that is why it is very important to sit down, have a look, plan, and then, you rightly said that sometimes you don't see the internal opening, but then when you are doing the surgery, when you inject a dye, you know where it is. Even if it is not coming, you can have a faint blueness there inside. So that is how you need to see. Thank you very much.
Thank you so much.